Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotations and you are more confident in caring for the critically ill patients. The use of point of care ultrasound in clinical medicine has been rapidly expanding. It gives you the ability to visualize the structure and function of internal organs and has an indispensable role in diagnostic evaluation of patients and for imaging guidance for certain procedures. In this lecture, I will talk about some basic principles of ultrasound that we need to understand in order to efficiently use this for patient care. Ultrasound waves are, as the name suggests, basically sound waves but with a frequency above the audible range. Sound waves don't travel as sine wave, they travel as compressions and rarefactions, but for the ease of representation, they are drawn as sine wave, with the distance between two compressions becoming the distance between two peaks, which is basically the frequency, and the density of molecules at each compression depicted as the amplitude of the sine wave. You may already know that bats generate sound waves and analyze returning signals called echoes to estimate the location and movement of objects. Ultrasound works on the same principle. The most important part of ultrasound is the tip of the probe. It has special crystals called piezoelectric crystals. When electricity is applied to these crystals, they rapidly vibrate and generate ultrasound waves. When the probe is placed on surface of a person using an interface like ultrasound gel, the sound waves or the ultrasound waves penetrate through the skin into the deeper tissues and are reflected back as echoes. The tip of the probe converts these echoes into electrical signals, which are then transmitted to the ultrasound machine. The machine analyzes the electrical signal and converts it into a grayscale image corresponding to the organ being visualized. The machine estimates the depth of structures based on the time it takes for the echo to return. For example, it takes shorter amount of time for an echo to return from this structure compared to a deeper structure like this. The depth is usually displayed in centimeters on one side of the screen. Each dot here corresponds to 1 centimeter. The same concept is used by something called sonar or sound navigation and ranging to estimate the depth of oceans. How dark or bright a structure appears on ultrasound depends on how much it transmits or reflects ultrasound waves. Fluid easily transmits ultrasound waves and appears dark. So any fluid containing structure like blood, bile, urine appears dark. This structure here is the cardiac muscle and it partially conducts and partially reflects ultrasound waves, giving it a gray appearance. This structure down here is pericardium and it appears bright white not because it is a dense calcium containing structure like the bone, but because it is surrounded by the lung which contains air. Air does not conduct or transmit ultrasound waves, so most of the ultrasound waves reaching the pericardium are reflected back, giving it a bright white appearance. This is an important difference to keep in mind between a CT scan image and ultrasound image. Bright white on CT scan means dense calcium containing structure like the bone, whereas bright white on ultrasound does not necessarily mean that we are looking at a dense structure. The term anechoic is used to describe black appearance. The term isoechoic means uniform gray, and the term hyperechoic means bright white appearance. There are three different probes available for point of care ultrasound exam. The most important difference to know is that high frequency probe gives you excellent image resolution but has a shallow depth of penetration, and the opposite is true for a low frequency probe. Let's start with discussion about linear probe. It has high frequency, therefore gives you excellent resolution, but only has a shallow depth of penetration. This is ideal for evaluation of superficial structures like blood vessels. In fact, it's commonly called as the vascular probe. Probably the most commonly used probe in point of care ultrasound exam is the phased array or square probe. It has low frequency, so the image resolution is not as great as a linear probe, but the advantage is it has excellent tissue penetration, making it ideal for evaluating deeper organs like heart, lungs, kidneys, etc. One special feature of phased array probe is that it has crystals that can generate waves in different directions and collect data from fast moving organs like the heart, making it ideal for assessment of cardiac structure and function. It can be used to evaluate any thoracic or abdominal organ. This probe is also known as the cardiac probe. Finally, we have the curvilinear probe. It is similar to a phased array probe in which it has low frequency, but the differences are the frequency is slightly higher than the cardiac probe, giving better image resolution and slightly shallower depth of penetration, but it cannot assess fast moving organs like the heart. So, this is commonly used for evaluation of abdominal organs and also known as abdominal probe. Here is an example of how high resolution probe gives excellent tissue resolution. On the left hand side, we have the linear probe, and on the right hand side, we have the phased array probe looking at the same structure. Here is an example of how lower frequency probes give excellent tissue penetration. On the right hand side, we have the linear probe where we lose the tissue signal after about 6 to 7 centimeters. But on the right hand side, we have the phased array probe which is giving a signal even beyond 15 to 16 centimeters. Here is the proper way of holding a probe. The ulnar side of the hand should be resting on the patient's surface. This helps with stability and also reduces fatigue. There are various movements or maneuvers of the probe that can be used to achieve best images of the organ being assessed. Here's what each of those terms mean. Sliding is movement of the probe across the patient's skin. Tilting is moving the probe without lifting it along this axis. Rocking is gently lifting one side of the probe. Rotation is twisting the probe along the vertical axis. To achieve the best clarity, the ultrasound probe must be held perpendicular to the structure being assessed. For this particular structure, this is the right position of the ultrasound probe. But if it is held at an angle, the image is not going to be as good. If the target structure is at an angle, the position of the ultrasound probe must also be appropriately adjusted. For this particular target structure, this is the wrong position of the probe, and angulating it appropriately would give you the best image clarity. So once you identify the structure, a fine combination of sliding, tilting, rocking, or rotating must be used to achieve the best image clarity possible. The shape of the screen or the image footprint changes depending on the probe selected. For linear probe, the screen is going to be rectangular. For phased array probe, it is going to look like a pie. For a curvilinear probe, it is going to look similar to a phased array probe, except that the top part will be curved instead of a pointed tip. Keep in mind that we are looking at three-dimensional organs on two-dimensional screen with ultrasound. It is very important to get properly oriented to the screen in order to identify the anatomic regions of the structures being looked at. To make it easy, ultrasound comes with what is called orientation marker. Each probe on one side has some kind of marker. In this particular example, a rounded raised projection, but the other side of the probe is going to be smooth. The orientation marker on the probe corresponds to the marker on the screen. Let's say I want to examine the liver in a patient, and I'm placing this curvilinear probe in the right mid-axillary line with the orientation marker facing the patient's head. Even before I start looking at the organs on the screen, I try to orient myself to the screen. I know that this marker is held towards patient's head, so this side becomes the top or cephalad side of the organs. This side becomes the bottom or the caudal aspect, and the top of the screen is where the probe meets the skin. So this is superficial, and as we go down, we are looking at deeper organs in this direction. Now it makes it easy to identify the anatomic areas. This is the liver in the middle, and towards the head there is diaphragm, which makes sense. Diaphragm is a dome-shaped structure with the convex aspect facing the patient's head, and that's what we are seeing here. And below the liver there is kidney, and that is what we are seeing on this side of the screen. If I show you this image of the kidney and ask you to identify the superior and inferior poles of the kidney, it is going to be pretty much impossible to answer that question without knowing how the probe was held. But if I tell you this is how I held the probe with the orientation marker towards the patient's head, then it makes it easy to identify, because that makes this marker M the cephalad aspect of the kidney, making this the superior pole and making this the inferior pole of the kidney. But if the probe was held this way with the orientation marker towards the patient's bottom, then this marker M corresponds to the caudal aspect of the kidney, making this the inferior pole and this the superior pole of the kidney. So it's very important to know how the probe was held in order to properly identify the anatomic aspect of the organs. Once you identify the target structure on the screen, there are a couple of important adjustments you can make to achieve the best clarity. One is brightness and two, the depth. It is generally a good practice to make the room dark by closing the curtains or blinds. This decreases the glare on the screen and improves contrast. But there is also a setting on the ultrasound machine that gives you direct control on the screen brightness. It is called gain. Depending on the manufacturer, it may be either a touchscreen control or a physical button. Here's how to use it. If the picture is too dark, you increase the gain, and if it is too bright, you decrease the gain to achieve the optimal brightness. The next important setting is the depth. Let's say I want to place a central venous line in this internal jugular vein. I want to make sure that I have good visualization of the internal jugular vein and the adjacent carotid artery. This picture is too shallow because I don't have complete visualization of the artery. This picture is too deep because there's a lot of extra space in the bottom half of the screen that I don't need. This is the optimal depth where I can visualize vein and artery completely. Depending on the target structure, there is an optimal combination of depth and gain. Ultrasound machine has preset combination of these settings. These are simply called presets. Let's say I want to examine kidneys using phased array probe. So I select the probe and simply select abdominal exam. But if I want to examine the heart, I change the preset to cardiac. Similarly, if I want to look at a blood vessel with a linear probe, I select vascular exam, and so on. Presets are a good starting point. So once you select the preset and visualize the organ, a lot of times you still will have to do some manual fine tuning of the depth and gain to get the best clarity. So far, everything we talked about an ultrasound image or video falls under 2D mode or B mode, which is basically a grayscale image or video of the structures being looked at. There are some additional modes available that will help us obtain extra information from the tissues and can be very helpful, especially when evaluating the heart. M mode depicts motion over time. Let's look at this example of IVC. It is collapsing with each inspiration. If I want to look at how much it collapses at a certain axis, I can do that using M mode. It helps me pick a line that I can place anywhere on the screen. And once I push on M mode, it gives me motion of structures just along that axis over time. So in this one screen, I can look at IVC diameter during inspiration, IVC diameter during expiration, and calculate how much it is collapsing with each breath. Let's look at another example. Here we are looking at what is called apical four-chamber view of the heart, and here we are looking at the tricuspid annulus, specifically the lateral part of tricuspid annulus. If I want to calculate how much this is moving with each heartbeat, I can do that using M mode. So I simply place the line along this axis and push on M mode, which gives me movement of this structure with each heartbeat. Using the inbuilt measurement tools in the ultrasound machine, I can actually calculate how much this has moved vertically and calculate something called TAPSE, which is an important marker of right ventricular systolic function. M mode has several applications, particularly for cardiac ultrasound. These topics will be covered in separate videos. Now let's understand the concept of Doppler shift. Let's take, for example, a static object like a parked car. Let's say this starts making sound. Sound waves are going to travel with equal velocity and frequency both in front of and behind the car. But if the car starts to move in a particular direction, the frequency of sound waves in front of the car increases and the frequency of sound waves behind the car decreases. This is called Doppler shift. By detecting this change in frequency, it is possible not only to estimate the direction of the movement but also the velocity of the moving object. There are two main types of Doppler imaging used for point of care ultrasound. First is color Doppler. This tells us about the direction of movement but does not help with calculating velocities. Spectral Doppler helps with calculation of velocities as well. There are some other types of Doppler imaging like power Doppler, tissue Doppler, etc., but we don't commonly use them for point of care ultrasound. Spectral Doppler is somewhat advanced concept. For the purpose of this video, we will focus only on color Doppler. Here is how a color Doppler works. If the Doppler shift is towards a higher frequency, meaning the object is moving towards the probe, then it gives red color. But if the Doppler shift is towards lower frequency, meaning object is moving away from the probe, then it gives a blue color. Let's take this example of a blood vessel where blood is flowing from left hand side to the right hand side. If the probe is held in this direction, then the flow of blood is away from the probe. So the blood vessel is shown in blue color on the screen. But if the probe is held in this direction, then the flow of blood is towards the probe. So the blood vessel will be shown in red or orange color on the screen. Here is an example of color Doppler of carotid artery. In this first example, the probe is held such that it is facing towards the patient's bottom. So the flow of blood is towards the probe and you're seeing an orangish yellow color on the screen. On the right hand side, the probe direction was changed such that it is facing towards the patient's head. So the flow in the blood vessel is away from the probe. Therefore, it is giving a blue color. So it is the exact same blood vessel, but depending on how the probe is held, the color can vary. So keep in mind that the color itself doesn't help you differentiate artery from vein. You need to know how the probe was held, and based on the direction of blood flow, you can tell whether it is an artery or a vein. Here is another example of application of color Doppler. We are looking at the left side of the heart on the screen. This is left ventricle, this is left atrium, and this structure here is the mitral valve. What does blue color indicate here? Think about it. Blue color means the flow is occurring away from the probe, right? So here the blood is flowing from the left ventricle towards the left atrium. That is abnormal and is indicative of mitral regurgitation. With this understanding of basic principles of point of care ultrasound, you are now ready to explore individual organs. In the next lecture, we will cover cardiac ultrasound. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from this lecture. Finally, I would love to hear your thoughts. Is there any part of this video you found particularly helpful? Is there anything I could have added to make this video more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.